ready to start the presentation. Get on to, okay. Well, greetings from Australia, everybody. My name's Ken Ware. I'm the founder of NeuroPhysics Therapy Institute on the Gold Coast in Queensland, Australia. The best place to come for a holiday. First, I'd like to thank the organisers of the event for hosting the event and giving us the opportunity to present our research under such challenging times. So my presentation today, I'm asking the question, do the net results of sensory systems deficits, deprivation deficits, create the initial conditions for the emergence of various classifications of motor neuron diseases based around noisy inputs will always infer noisy outputs. So first we sense our world and then we respond to it. So based around some of the studies and the research we've done, and in particular the outcomes for particular patients that we've had with various types of motor neuron diseases, we see evidence that yes, a lot of the times there's sensory deprivation. So hopefully we can throw some light on that question as the presentation goes on. So what is neurophysics therapy? Well, neurophysics per se is a branch of medical physics in science, and that's dealing with the development of physical techniques to gain information about the human nervous system. And basically they're studying perception, action and cognition and using technologies like functional MRIs and PET scans to do that. So it's usually done on that molecular scale. Neural networks and complexity science are just some of the tools that are utilised to make sense of the data and to develop theory. Neurophysics therapy per se, I founded that back in the early 1980s and has since earned its own footprint within this branch of science. And at the time I developed some special techniques to gain real-time information about the functionality and the behaviour of the human nervous system and how it perceives and responds and interacts with the environment. And so basically neurophysics therapy is the study of the functionality and behaviour of the human nervous system and how it perceives and responds, interacts with the environment, and the development of specialised techniques to optimise the system's functional and behavioural potential to accomplish specific outcomes. So it's recognised as a highly sophisticated exercise-based method and treating a very wide range of disorders. So I've been relatively successful over the many years. There's been lots of international media attention paid towards the outcomes, so 60 Minutes and different front page of different international newspapers, BBC and so forth. So a lot of that relates to spinal cord injuries. Some of it was to do with this young boy, British boy, was born with only 2% of his brain, and miraculously that brain actually grew to 80%. We didn't have much to do with that, but spent a bit of time actually helping that young boy to regain some function or gain some function in his lower limbs. So it's been a big journey for many, many years, and it all accumulated in the Academy Award nominee Steve Kozlowski's award-winning documentary Calibrate, which is a beautiful film about many of the people who come from all over the world for neurophysics therapy. It's won many awards at international film festivals, and if you ever get the chance to see it, like I said, it is a beautiful film. So the question is, do sensory system deprivation, does that create the initial conditions for the onset, the conditions for the emergence of the onset of motor neuron diseases? So first we ask the question and then we sort of look at how we can answer that. So what are motor neuron diseases? Well, the motor neuron diseases, we know they're a group of progressive neurological disorders that destroy motor neurons, and the cells of skeletal muscle activities such as walking, breathing, speaking and swallowing. So there are many classes of it: ALS, primary lateral sclerosis, progressive muscular atrophy, spinal muscular atrophy and so forth. And so normally the messages from the nerve cells, the upper motor neurons, will send messages to lower motor neurons that are located in the brainstem and the spinal cord, and from there into the muscles of the body. So upper motor neurons direct the lower motor neurons to produce muscle movements. So when the muscles cannot receive signals from the lower motor neurons, of course, they begin to weaken and shrink and atrophy and become weaker and weaker, and the muscles also start to spontaneously twitch at times. So when the lower motor neurons cannot receive signals from the upper motor neurons, of course, it produces muscle stiffness and spasticity and overreactive reflexes. And that's an area there where we're sort of looking at probably having another lens at that, because we know that it's indirect cortical spinal pathway that creates that background tone in our system, and that receives input from the emotional regions of the brain. And a lot of the times, as we'll get to discuss in more detail, a lot of the people that we've seen, well, all the people that we've seen who developed the motor neuron disease, there's been a lot of long-term stresses involved and high levels of anxiety, high performance type of focuses, and so forth. So these can make, obviously, there's a great deal of difficulty there, and it's a type of disorder that, of course, that can be very challenging to people involved. I just need to probably get rid of this screen up there. Okay, so how are they classified? So whether the loss of function generation is inherited or passed down through genetics, so family history, sporadic, no family history, and that's more the areas that we've been working through, whether it affects upper motor neurons, lower motor neurons, or both. And in cases where motor neurons with the disease are inherited, it's usually caused by mutations in a single gene. So MNDs occur in both adults and children. Children is specifically due to a gene mutation. Symptoms can be present at birth and so or an early child or appear in early childhood. In adults, MNDs are more likely to be sporadic, meaning the disease occurs with no family history, and symptoms typically appear after age 50, although the onset of the disease may occur at any age. ALS, for example, commonly strikes people between the age of 40 and 60, but can happen in younger and older people, and men are slightly more affected more than women. So most ALS cases, about 90%, are considered sporadic, and family members and those individuals are at increased risk of developing the disease. So there's individuality at play here, and that's what we're sort of looking at as being very important. And it is this demographic that is of interest to this research and hypothesis. So what causes sporadic MNDs? The cause of these are basically unknown. So the hints at environmental, toxic, viral, and so forth. Genetic factors may play a role in the development of the disease. There are several different types of MNDs that cause muscle weakness. They gradually worsen over time and leads to disability. So ALS, also called classical motor neuron, affects both upper and lower motor neurons and causes rapid loss of muscle control and eventual paralysis. Early symptoms of ALS include muscle weakness and stiffness in the limb or muscles of the mouth or throat, and gradually almost all the muscles under voluntary control are affected, and individuals lose their strength and ability to speak, eat, and even breathe. How are they diagnosed? In many cases, there are no specific tests for diagnosis of MND symptoms may vary among individuals in the early stages, and they can be very similar to the other diseases, making diagnosis difficult. So it is often a very big call when somebody actually gets determined that there's some motor neuron disease. So there are a couple of tests that should be done simultaneously, and unfortunately, I see a lot of evidence in Australia, at least, that isn't done in favour of just a nerve conduction test, a single nerve conduction test that then is used to determine whether a person has a motor neuron disease. So typically EMG and to determine whether it's a muscle, something to do with the lower motor neurons, and it's able to be able to detect whether there's a difference between muscle diseases and MND. So ideally they're done between both. So other tests like MRIs and so forth can be helpful also. So what is the prognosis for MNDs? And I said this is where the water gets very muddy. So depending on what practitioner you often see as to what the prognosis is going to be, and we see Stephen Hawking's over there, who obviously defied his prognosis for many, many decades even. So very depending on the type of MND and age and symptoms at the onset. MNDs such as PLS or Kennedy's are usually not fatal and progress slowly. So they're but people with SMA type 3 may be stable for long periods of time. In some forms of MND, such as the severe form of SMA and ALS, are fatal. But however, according to Dr. Stein from the University of Queensland in Australia, he makes a very general statement which has quite a big effect on how people are diagnosed out in Australia. And the following diagnosis, patients have an average of life expectancy of 2 to 5 years, but there's a great deal of variability from person to person. And there is no caveat in the statement to suggest survival is possible past this average, or that is it depending on what type of motor neuron disease it actually is. So typically when people get told that there's a motor neuron disease, and this is the talking point, it seems that the seemingly large variability between what the patients are told that their prognosis is likely to be from one practitioner to the next, along with the acuity of the diagnosis that we find very concerning. Giving a person an MND diagnosis in front of any real deterministic values can become a death sentence in most cases. For example, there's a huge chance that the same patient were diagnosed with MS instead of an MND, that they would go on to live much longer under much less stress. So how MND is treated, there's no cure or standard treatment for MNDs. Symptomatic and supportive treatment can help people affected with the disease are more comfortable while maintaining a quality of life. And then multidisciplinary clinics have specialised in neurology, physiotherapy, respiratory therapy, and so forth. There's certain drugs that, even though they're known to have very minimal effect, that are so often used. But basically, there is no cure or standard treatment for MNDs, as far as the standard paradigm suggests. So the scope of our study involved 5 MND diagnosed patients, and it was limited to 2 male and 1 female ALS sporadic cases, 1 male sporadic SMA and 1 male ALS familiar case. And this case was viewed as a control for the sake of the initial study. So all of these patients agreed to give permission for the images displayed in the testimonials. So the patients ranging from 24 months to 2 months post-diagnosis, range of symptoms varied across patients and included loss of voice, non-verbal, one particular person, 6 weeks prior to the study, the treatment, difficulty in breathing, coughing, significant loss of limb or range of limb movements. The trial consisted of 4 days only of intensive neurophysics therapy, and the outcome of the trial treatment, all patients inclusively of the familiar case, achieve above mild to moderate measurable returns of loss of most of their dominating loss functions. Now, just hopefully these videos will actually play, or they'll play, but hopefully you can hear them. If you can't hear them, there's probably not much point in listening to them going through it, because it's very important to hear what these people actually have to say. So we'll see how it goes when I click onto it. Can the viewers actually hear this?
I'm not able to hear anything yet.
Yeah, okay. Yeah, it's a bit of a shame, because I don't know what we need to do to actually get the sound my computer, but if we can look at the images to see that these people come in quite restrained states, and part of what you're seeing in this particular woman is the freedom of movement that she's experiencing from the therapy itself. And we'll talk more about those dynamics later on. This was the SMA patient. He was not able to walk unassisted prior to doing the therapy. So they had some pretty profound statements to make, and like be reminded that this was all accomplished within 4 days of neurophysics therapy, and based around the fact that if we're looking at this person talking, so that particular person up there, he was the person who could not speak for 6 weeks prior to it, and after the first day of therapy, he was able to start to say words again, to the point that he was given this testimonial. This fellow on here, just explain. So again, it was an ALS case. He had very limited upper limb movement, and yet he was able to move those limbs quite freely. And Henza down the bottom there, again, he had pretty limited lower limb movements, which didn't sort of improve a great deal, but his upper limb movements improved quite dramatically within that period of time. So we're just getting onto the fact that the talking point is about the diagnosis. So patients being diagnosed with having an MND in the absence of clarification is certainly highly distressing to the patient and their families. It's critically important for this to be an accurate conclusion. And good science is, of course, is being sure you know what something isn't before concluding about what something is. The excessive nervousness of a patient when being assessed for possible MNDs, combined with possible long-term psychophysical hypervigilance, may allow for misinterpretations of what the data is informing the inquirer of in a one-time conduction test analysis, for example. There are far too many variables involved to jump to conclusions from some of the systematically biased physical observations that are made. Fear, nervousness, and anticipation of what the diagnosis is going to be may influence the data towards a positive diagnosis of MND if the neurologist, for example, has an MND mindset. Even though in the cases where it can be determined that there was a misdiagnosis through more systems-wide tests, performed in a safe, supported environment, it is very difficult to detrain the fear of imminent death that an MND diagnosis causes, which complicates progress of recovery from the psychophysical conditioning of the patient who is diagnosed with having an MND. And potentially the novel assessment techniques I will introduce further on will help to reduce the consequences of an incorrect MND diagnosis and possibly challenge the acuity of an existing MND diagnosis, for example, that was based upon presentation of symptoms, or in cases where has been a one-time conduction test performed. Excuse me. So some of the simple observations and baseline measurements from the initial conditions of patients diagnosed with MND pre-NeuroPhysics therapy, what we see across all these patients is the long-term posture neglect. Now, everything innate, the natural world has evolved with a physical structure that optimizes performance and functionality responsive to and measured against the only constant there is in gravity. So all biological systems have developed a framework to be able to have been evolved around that and been programmed to that and basically calibrated to that vertical constant. And our studies are so new, have presented with MDIM coinciding usually with other psychophysical conditions, is that each patient has maintained very long-term significant posture neglect. And for the human being, optimum psychophysical performance emerges from good posture. Anything less than good posture equates to a drop-off in physical emotional performance and compromise our relationship with it and our perception of our environment, with perception being very important. All animals have evolved a sensory motor apparatus to enable them to navigate through their environment in an optimal manner to enhance their survival and the survival of the species. And humans are more emotionally complex, and the emotional regions of the brain have a determining influence over the posture of a person at any point in time. So, for example, a person suffering from depression will exhibit a compromised posture during peak periods of depression. So we see over on the top right-hand side there, just that neck position for alone, the perturbation to the stress on the brainstem. So upper motor neurons communicating to the brainstem, where there's a significant perturbation to that brainstem. Some stress there is most likely going to interfere with communication, lines of communication. So we need to have a nice, clean line of communication going through there. So it's just putting that kink in the pipe, so to speak, it makes it more difficult. So compression in that particular area. They have compromised proprioception. So I'm using a healthy control here to demonstrate this. Obviously, with patients with MNDs, we can only work with people who still have maintained a bit of some upper limb functionality and lower limb functionality at this point in time while we're pursuing with our studies on this. So what they have initially compromised proprioception, and proprioception is where my body is in space, time, or things at a distance to me. But proprioception is just nested within our perceptual landscape as to what we perceive to be our reality. So if we see errors in perception, and these people were having with their eyes closed and trying to relax and just very slowly bring their index fingers across their body to touch in the middle there, that's where we see a lot of errors occur. And we can often pick up a hemisphere bias because their body will favor moving off to one side more so than the other instead of being able to center it up. Going from finger to nose and nose back to the finger game, they're very poor depth perception. So they have a very much loss of perception in that case. But like I said, perception is interconnected with all other percepts. So they see that there's sensory perceptual errors taking place that leads to poor motor responses. So other simple observations are high sympathetic nervous system tone, so permanency of tension in the trapeze muscles. They're very intimately reactive to the sympathetic nervous system events, but these people have long-term hypervigilance in that particular area. So it's almost like they've been in a constant fight or flight state for many years, of course, which is driven by perception of environment and obviously their emotional states. The hypervigilance or excessive tone and background tone in them due to mild perturbations. So you see images of they're butterflying the person's legs back and forward. They're trying to relax. And as soon as you start to do that, their muscles tense up very quickly, so they become hypervigilant. And their ability to be able to switch that off is very poor. So the limbic system, the emotional regions of the brain are very much overreactive. So they're perceiving basically non-noxious information as noxious. They cannot perform that abduction, adduction by their limbs very well at all, of course. So The signal to noise ratio is very high. They're trying to send signals through, and that is a very fundamental movement. So when we're children, we tend to sit on benches, we'll flop our legs back and forwards, and it's the brain constantly synchronizing itself to be able to maintain that stability there. But of course, when stresses come along, giving a direction to the left leg or the right leg becomes more cumbersome. So as the person's walking around, then there's different messages going up to the brain. So every time they put their left foot down, there's a different message that goes to the brain about where they are in space-time, and likewise with the right foot. And of course, because of that disparity, their system is more likely to maintain a hypervigilant state to trying to protect itself. And of course, rarely standing on one leg at a time is very difficult for these people. With their eyes open, standing on their leg, one leg at a time with their eyes closed is literally impossible for them to do. But the point about all this is this is where the simple elegance comes in. Even though we're taking these samples, but we always see with practice, when these people just learn how to just relax more and start to do some of these movements, just put a bit of focus on it, as time goes on, we can start to see that changes are occurring there, because they're getting cognitively involved with what's taking place. They're learning how to control their arousal better. And as soon as they start to do that, other things start to come back online. So when we have this permanency of tension because of the sympathetic nervous system, obviously the parasympathetic nervous system can't do its job. The system is taking in information from the outside world, but it's not responding to it very well. And it gets back to the argument, are we looking at sensory system issues here? Because first we sense and we perceive and then we respond. The motor neurons basically are the slave of the sensory system, so to speak. So if they're not getting input from the sensory system, well, it's anyone's guess what that's going to happen after that. So to look at it through a more different lens of complex adaptive systems and chaos theory, like psychology and nonlinear dynamics perspective, we had to sort of put aside a lot of the existing medical research information and protocols presently available on MNDs, and then we asked the question, so exactly what I said, what are we looking at here? For example, why would it suddenly in later life begin to display destructive rogue patterns of behavior? And why do these random sensory motor fluctuations inform us of in relation to the state of the system and its relationship with the environment? So it's well and truly understood and identified that complex adaptive systems are scale-free systems, so fractal physiology. So what's happening at one scale is happening at all scales of the system. It gets back to what I was talking about, proprioception. So the relationship between events occurring in living and non-living complex adaptive systems, other than human beings, the events we're interested in here at any point in time are also scale-free. So we'll delve into the relevance of this and the onset and evolution of MNDs deeply as we progress through this course. So complex adaptive systems are very sensitive, dependent upon their initial conditioning, internal, external initial conditions, where tiny influences can have a major effect. So hence the butterfly effect, which is more or less an analogy to describe that tiny fluctuations can have a major effect. And human beings are extremely sensitive to initial conditions due to their high order perception and emotional elaboration on the environment. The inference here that if these systems restraints, the MMDs are magnification of the system's underlying kinetics. So these are the sets of initial conditions that are giving rise to the macro psychophysical representation of these individuals, which is following the same sets of rules that apply to all living and non-living complex adaptive systems. Unfortunately, in the case of these MND patients, an undesirable portion of their macro psychophysical representation is taken up with the emergence of their symptoms. MND symptoms are emergent phenomena, classified as emergent phenomena. The simple beauty and elegance here is by altering the system's initial conditions in a prescribed manner, that these modulated sets of initial conditions will now enable for the emergence of more desirable patterns of psychophysical behavior. And metaphorically speaking, it's like tweaking a slight algorithm to a cellular automaton, a slight alteration to a cellular automaton algorithm that gives rise to the system's structure and function. So I'd just like to elaborate on what I've basically been studying for many years, the fact that the underlying states of the human nervous system are chaotic. We know there's plenty of studies to show that the resting state of the healthy brain is chaotic, but again, it happens at all scales. And what I discovered many years ago, that under certain conditions, when a person is being relaxed and they're stimulating their system in a very slow, meaningful manner, that a slight tremor will begin to appear. And that tremor has basically been ignored. And what I discovered by the person learning to let go, that it very much exposes these underlying chaotic states of the system. And in that state, this is when the system is able to very much reflect upon itself and see what's normal and what's normal and start to correct its own errors. So this is the part that's been very successful, and we have a very strong history of what we've been able to accomplish with people with spinal cord injuries, both complete and incomplete spinal cord injuries. So the whole purpose of the person learning to let go, let these underlying dynamics evolve, which basically map out exactly where the system's at, how it's communicating with this environment. We can literally see the noise that's in that part, so we can determine whether there's disease or disorder in that system based around what those dynamics are telling us. But also at the same time, we know that if the person just learns to let that go, that the system will naturally dispose of its noise and then stabilize in a much more complex area as time goes on. So we're just going to play this little clip from the movie Calibrate, the documentary Calibrate that I was talking before. I hope that you can actually hear this. So that gives you an example. So whilst it might look pretty confrontational, those people are perfectly coherent. The person in the blue t-shirt that you've seen on one of the benches that I was working with, he was a complete spinal cord injured person. And in that state, his system was certainly displaying behaviors as if there was no injury there whatsoever. So we know the resting state of the healthy brain is chaotic, and it's when the brain becomes less chaotic that the pathologies emerge. So Lapomedes and co back in the 90s, they had these patients in hospital where they were doing studies on their brain to sort of basically try to find an area where they could create a lesion. So these were patients that suffered very chronic epileptic seizures. And what they see, so you see the 5 probes that they put in the brain at different locations. And what they seen that as time went on, approximately 50 minutes before a seizure would occur, that these areas of the brain would start to become highly synchronized. And it's at that point there where the seizure would occur, where the system then set about disposing of all that excess energy and overorderliness to stabilize itself in a much more desirable place again. So it's this building up and this over-synchronization where the brain becomes too synchronized that causes the problem. Now, what is very interesting about all this is that, and you can do some research on this yourselves and you'll find it super interesting, is that seismologists see that the same type of phenomena appears before an earthquake, and it actually follows exactly the same power law distribution as what the buildup does of a seizure and what pre and post seizure. So the earthquake itself is the event where the earth is releasing that excess energy. So there was quite extensive studies that were done over many years, and it's very interesting to see again that nature uses very simple rules and that apply to all systems all the time. On the right-hand side there, we had one of our patients who came to us with chronic epileptic seizures, 15 years of dealing with those. So we had EEG sort of markers. So there was 4 EEG markers that we actually used on left and right hemisphere. And as you can see there, there's a very high level of synchronization taking place across all those channels there. So the playing a little bit of music, it was a popular Beatles song, just a low sounding Beatles song. And we see that the brain very quickly synchronizes to, which is pretty much a signature of the epileptic brain. And after 4 days of therapy, playing the same music, exactly the same music, we see that that wasn't the case, that there was much less synchronization taking place through there. So, the person again was able to learn to let go, allow their body to move into that state where we can see all those chaotic, the underlying states of the nervous system. And that way was able to dispose of this excess energy and overorderliness in front of any seizure. So it was a technique that the person learned to use then, so able to avoid seizures from there on in. And as a result of that, some of the other pathologies that the person was suffering were very much alleviated. So getting into the question again, so first we sense and then perceive and then we respond. So the MMDs are there for accumulation of either rogue sensory percepts the individual has made, or rogue motor responses, or both. So is it a sensory systems deficit or a motor systems deficit? So for perception means everything for the human being, how we perceive our world, and our world frames and organize how we respond to it behaviorally. And if we need to make an alteration in behavior of any system that displays rogue characteristics, we need to alter perception. And when we look at Stephen Hawking as a case, for example, it's no secret that he locked himself in a dimly lit room in Cambridge for many, many months while he was doing his dissertation. He wasn't out socializing, so he had very poor, like I said, there's very poor light, very sensory deprived in that case. And as we know, the motor neurons are the slave to the sensory system. So after a long period of time, things got worse. And of course, he fell over in a courtyard and got tested, and the rest is history. But if you locked anyone in a room like that for that period of time, and suffering the same level of sensory deprivation, we probably could safely say that we understand that there could be some issues because of that. So on the right-hand side there, we see one of our patients that came to us with MND. So these were markers. The top two markers were EMG markers on the right and left trapeze, EMG on the right and left abdominal wall just adjacent to the navel, EMG on the adductor process in the lower limbs, and then we had the ECG and the EEG, of course, there. So the datum displays random systems-wide overall highly synchronized events occurring in this patient's psychophysical system, and the emergence of these events was sensitive to the system's sets of initial conditions, which intimately involves perception of their environment. So comparative data now that we see on that same bit of data that we just looked at was over the left-hand side of that person pre-NeuroPhysics Therapy. On the right-hand side there, we see a healthy control at rest, pre-NeuroPhysics Therapy day 1. So we see the same markers, and we see that there's, even though it might look like there's synchronization there, but there's a level of organization through every channel there, a lot more degrees of freedom in the EEG, and then we come down to day 4 after the left of the MND patient at rest at day 1. This is post NeuroPhysics Therapy, so we see that there's already a relaxation of some of those restraints. The system is starting to open up a lot more, so there's many more data points within that data there. And on the right hand side there, that was day 4 at rest post NeuroPhysics Therapy, so we start to see that it's starting to look a lot more normal. So we can appreciate the difference between day 1 data up there and what we're seeing on day 4 data. So other types of studies we've done along those lines with involved in the sensory system and with motor. This one particular one was for muscular dystrophy. So we've done a mutual information analysis of sensory motor rhythms in this subject. So we see the normal of the healthy subject up there. So what that would all look like. This was the person, the subject with the FSHD on day 1 pre-NeuroPhysics Therapy. So we see that there's lots of disorganization there, and we're seeing that things are starting to normalize again day 4 NeuroPhysics Therapy. And that person, despite the fact that FSHD is supposedly a genetic disorder, that person did restore quite a significant amount of function in that period of time. So again, what were the genes doing at that particular time to allow for the return of those functions? So observed in these patients that increase in anxiety levels amplify symptoms effects, and this becomes a positive feedback loop. So the person gains a few start to have a few symptoms. They put awareness on those symptoms, and of course, as their awareness goes on the symptoms, their anxiety levels increase. Their anxiety levels increase, the symptoms increase, and so forth. So it shows the direct influence on the brainstem, the thalamus and motor cortex. And the amygdala is a direct influence on the brainstem, melanocortex, and so forth. So NeuroPhysics Therapy involves a super slow, self-controlled, hormesis-like perturbation of the patient's central nervous system. So as you see a person there doing one of these exercises, now those machines are unilateral, so those arms move independently. They're moving along a fixed plane trajectory, so the machines actually provide a very stable grid that we can measure changes that occur at each point in space-time. The weight on the weight stack there is moving up and down according to the laws of gravity. So our bodies understand gravity, so it's a rule that it's complying to. Typically, as that person starts to move that, which is only a very mild stimulus that they're initiating themselves, and they start to move those across their body nice and slowly, that's when we start to see a lot of the underlying anxieties and fears begin to emerge in that person. That really shouldn't be there because they're in a safe, supported environment. There's no lines running around the room. They have all the control. All they're being asked to do is close their eyes and come across their body nice and slowly. And of course, it starts to elicit all these rogue responses to it. So at the end of the day, it basically means, again, they're perceiving non-noxious environmental stimuli as noxious. So we got to set about then detraining all those responses. So, you know, it can be quite little bit at a time we go through. They start to feel that arousal coming up. They learn to stop, control it, calm it down, get a sense of flow and distribution taking place through their system. So we've got to talk them through that little bit at a time until they start to detrain that and up-organize the way that the amygdala is communicating to the system. So neurons in the amygdala that should be reporting safety and comfort have somehow crossed over at some point in time and now are reporting fear and anxiety in situations where there shouldn't be anything around. But it's all based around history, the past experiences. A person's system doesn't start inventing responses because they're sitting on that machine. It reflects upon its history. So when stress reaches a certain threshold, there's an associated experience there with other types of events that occurred in their life. And it's the accumulation of those events, unresolved perhaps. It doesn't really matter. We don't need to know the details of those events. All we know is that those events are affecting the person's behavior and their function. And by detraining those responses there, the person then slowly but surely other things start to come back online, because that's what's been maintaining this background of hypervigilance. So whatever we see emerge in the person when they're doing these type of exercises, that's their default responses. That's how they're perceiving their environment all the time. So it always comes down to treat the person and not the disorder. So we need to correct sensory perceptual errors to elicit systems-wide improvements. So I have a bit of a grid drawn over the machine there. So like I said, we can take reliable measurements that the machines actually afford for the sake of, you know, learning what happens when stress reaches certain thresholds. There's a whole series of machines that people go through, because each time they come through a different pathway, it elicits different types of emotional responses that relate to our overall emotional package and our perception of our environment. So we've got to go through all those and just correct all those errors along the way. And then the person develops a whole new terms of reference or frames of reference within their system that become very reliable and much more predictable for them. So I'd like to thank everybody again, the organisers for the event, and thank you everybody who's persevered with me through this presentation. It's quite late at night here in Australia, so I've been talking all day and it's getting a bit puffed towards the end there. So I'd like to thank everybody, and especially the thousands of patients who trusted in my methods over the last 35 years or so, and for all the many assistants and NeuroPhysics Therapy practitioners who helped you evolve the international reputation of NeuroPhysics Therapy to where it is today. So thank you very much.
Thank you so much, Dr. Ken, for your wonderful presentation. Now floor is open for the questions. If anyone having the questions, can raise the hand. I guess there is no further questions. Doctor, thanks a lot for your wonderful presentation.